So I'll be brave if you're brave. I'll be brave, but only if you're brave.
I'm Danielle Hicks, Chief Patient Officer here at GoTo Foundation for Lung Cancer. Today we'll be talking about biomarker testing. Biomarker testing and increasing the rates of people being tested is one of GoTo's main goals. And we hope today that our audience walks away understanding what a biomarker is, what biomarker testing is, who should get the testing, when the testing should be done. And I think you'll find that Dr. Benjamin Levy, who is coming to us today from Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital, is just the person to explain all of this to you. So let's just kind of jump in.
Yeah.
When we say biomarker testing, it comes by many names. Sometimes it's molecular testing or genomic profiling or next generation sequencing. But at the end of the day, when we use a term biomarker or something similar, what are we talking about?
Yeah. Well, it's a little confusing, just as you mentioned here, because there's many paths to Rome. And so you're talking about next generation sequencing, molecular testing, genomic interrogation, biomarker testing, molecular profiling. They all mean the same thing. So you may get confused when you're out there hearing different experts talk about different things, but it all leads to the same process, which is really simply trying to understand the DNA makeup of a tumor, identifying markers or genes that are relevant for the lung cancer. And then once you have that genetic alteration or biomarker or gene or DNA makeup of the tumor, and you've identified that particular marker, you can then wed that marker to a particular therapy. And this is, again, true personalization of treatment. So they're all the same thing. We obviously do a big panel of genes that we look at, and if we find a particular gene, we wed that gene to a particular therapy. The nice thing about this in lung cancer is that if you have one gene, you don't have the others, which is truly unique. It's a nice story. So if you could think about a pie or a pizza pie, and each slice of the pie is a different gene. And so if you have this sliver of the pie identified, everything else is sort of ruled out. This is a clean story in lung cancer. If you have gene A, you get drug A. If you have gene B, you get drug B. But you very rarely have both gene A and B. So it's a really nice story. I'm a simple guy. I like simple stories, and this is kind of simple. So it's a really easy paradigm and flow to follow.
It's interesting because in talking with patients over the years, I think one of the things in trying to explain biomarker testing that I share that I heard long ago was it's really important just to really kind of break it down into the most simple terms to figure out sort of who's driving the bus, right? Like what is driving your cancer? Because what is driving your cancer might not be what is driving someone else's cancer. So,
Yeah, lung cancer
so
is many, many different diseases. One patient's lung cancer is not the same as another. It's such a heterogeneous group. This is a testament to the science. We're so just thinking that lung cancer was just one disease and everybody was getting the same treatment. And that treatment, unfortunately, was this, in my mind, archaic way of like just giving chemotherapy to everyone and then crossing our fingers. And that's not what we do now. So, I mean, it's really important for patients to ask their physicians, what is my molecular profiling show? And, oftentimes patients have to be their own advocates. I hope they don't have to do that at Hopkins because I try to advocate for patients, but for better for worse, there may be people out there that don't understand this. And so patients have to take the bull by the horn sometimes and say, what is my gene? And how does that play in decision making?
obviously in the large academic centers like where you are able to treat your patients, it's not always the same in the communities, right? Particularly in some
Right.
more rural areas. And I say all the time, because sometimes patients will be like, well, why do I need to know this? Shouldn't my doctor know this? And it's like, well, I guess the short answer is yes. But in lung cancer in particular, things are happening so fast and so furiously that what anyone thought they knew last week might have changed this week, right?
Yeah.
So it is so important to
Yeah.
continue to sort of, poke the bear, I guess, if you will, in having this conversation.
The field is dynamic. It's constantly moving. It's hard to keep up. I mean, the running joke in our institution is sometimes even as lung cancer doctors who live in this silo, We have a tough time keeping up with it. Like this is all I do. And
Yeah.
sometimes I'm confused what the new study showed, what the marker is, how relevant it is, what are we looking at. If I'm having a tough time keeping up, the community that sees everything is going to have a tough time. And I think we've seen sobering results recently to suggest that, in the community setting, we're not doing molecular testing as often as we should. In fact, half of patients aren't getting molecular testing. And there's a lot of reasons for this, and it may not be physician related. Sometimes it's trying to get the biopsy, and we can talk about that and how hard it is, but we have to do
Mhm.
better. And some of this obviously starts with us and educating the providers that are out there, but also educating patients like we're doing today and saying, look, partner with GoTo, get to partner with other philanthropic and advocacy groups so they can help you along the way.
Yeah, I couldn't agree more. And I tell folks, I mean, you hit the nail on the head when you're talking about a general oncologist working in a community center. Again, particularly in some of the more rural areas of this country, and there's more rural areas than there are not, right?
Yeah,
Um, they are treating whatever walks in the door in between solid tumor type cancers such as lung cancer and also blood cancers, right? So
yeah,
there are, many, many, many things for these guys to kind of try to figure out and understand. So
yeah,
I do agree that it is important, and we truly believe, as I said sort of at the beginning of this meeting, that empowered patients do better. I mean, they just do. So we talked a little bit about what a biomarker is. We're looking for who, I say who, as though it were a person, but what is sort of driving your cancer. Once we can identify that, we can look to see if there is a drug that is paired with that biomarker that will work best for that patient. Who typically orders this test?
yeah. That's also dynamic.
Mhm.
And this will be a recurring theme and narrative that I talk about throughout this session is that in lung cancer, it takes a village. It's not just me, but it's the pulmonologist, the interventional radiologist, the surgeon, the radiation oncologist. Every center is different on who orders this. At Hopkins, it used to be the pathologists. We did what's called reflexive testing, where essentially once that biopsy was sent to the pathologist, no matter what, the pathologist would send it out. We've had some challenges with that, and I don't want to get too much into weeds, but now what we do is have the biopsy, the person who's doing the biopsy, order the tests. So we've worked out our system in EMR where an interventional radiologist who does the biopsy, the pulmonologist who does the biopsy, essentially emails the pathologist and puts an order in our EMR to order that test. It would be great if it was reflexive, and I still think best practice is reflexive, meaning once the tissue arrives in the pathology, it's done, it's sent off. But every center is going to be different. I know centers that allow the pathologist to order it. Sometimes the medical oncologist orders it. I will say that I do follow up on the results. I mean, we had a case last week where the tissue was sent, but it wasn't sent for everything. But it does take a village, and every member of that village probably plays a different role for molecular testing depending on the center you talk to. I do again think best practice is reflexive testing, but that doesn't happen all the time.
And so I just want to clarify for those that might be watching what we mean when we say reflex testing. Can you kind of walk through that for the folks?
Yeah, so reflex testing is when someone does a biopsy for a suspected lung cancer. That tissue initially goes to pathology, and the pathologist looks at it under the microscope, makes sure that it's lung cancer. Reflex testing essentially is once the pathologist makes that diagnosis, he or she automatically sends it out for molecular testing. That testing is not done by that pathologist. The pathologist then sends it to a lab where the testing is done by special machines, which are very complicated, which do the sequencing or understand the genetic underpinnings of a tumor. And that's best practice because we can talk about how challenging this is with turnaround times. The pathologist gets it, and if they sent it out automatically without anyone having to follow up or anyone say, hey, Dr. So and so, you need to send out the test. If it's sent out right away, you don't have to worry about that, and you get the test back result quicker.
Yeah, I think this is such an important piece because to your point, ideally this is best practice, right? The
Right.
biopsy is done, the tissue is sent. We aren't just looking to confirm whether or not it is cancerous, but we're also upon finding out that it is, automatically sending out. And I think, unfortunately, and I've been arguing for reflex testing for many, many years now, real world, in fact, does not show me anyway that reflex testing is happening everywhere. So again, this is another point about why it is so important that the patients
Right.
themselves are understanding, hey, if you're going in for a biopsy, have this conversation with your physician. Like, will this
Right.
automatically be tested? So when this testing happens, there are also different types of tests, right? So sometimes there's single gene or a limited panel of testing, and sometimes there's
Right.
comprehensive testing. Can you talk a little bit about the differences
Yeah.
in the two?
This is again sort of the testament of how far we've come, not only therapeutically, but diagnostically. When we started this 10, 15 years ago, we were doing something called single gene testing, which is essentially like we wanted to find one or two genes, and that's all we were looking for. Because at that time, we thought that's all that's irrelevant. Let's just do tests for what we, gene A and gene B, and that's it. So that was at that time, it was EGFR and ALK. These are two
Yeah.
relevant genes in lung cancer, and this was kind of the chapter one of the personalized medicine story in lung cancer. And that was great at the time. And I think what we've learned over the past 10 years is that's not enough. We can't just test for two genes. Unfortunately, in the community, and there's still people that are doing single gene testing. And so we fast forward 10 or 15 years. And given that all there's these new drugs that are available, we've done a deeper dive into the tumor and we're able to sequence the entire DNA makeup of the tumor, and that's called next generation sequencing, and it's next generation, it's moving the field forward, and that's abbreviated and that again is really just not only looking for just EGFR and ALK or gene A or gene B, it's looking A to Z, every single gene that's out there in the cancer we look at now. This creates complexity because you get the result back and you see 20 or 30 different genes that may be altered or mutated, and you have to pick the ones that are relevant. But once again, this we know now that patients that get upfront next generation sequencing do better than those who don't get it or get another type of test. So it's really important that everyone is doing next generation sequencing on their lung cancer patients.
Yeah, not to mention turnaround time, right? If you're only
Right.
testing for one mutation at a time, that takes a long time to get done. And anxiety is a very real thing for someone who's diagnosed
Sure.
around
Sure.
getting started on treatment. How is this testing done? We've talked about biopsy, but let's step back a little bit and say through some sort of diagnostic, be it a CT scan or an X-ray, incidental finding, however it has come to be that somebody needs to move forward into a biopsy. How are these biopsies done?
There's a lot of different ways to do a biopsy, and this is where again it takes a village and it takes some time to figure out what's the best way to do it. So, the two most common ways to get tissue are by either what we call bronchoscopy, specifically most often an EBUS, or what's an endobronchial ultrasound, which is a complicated way essentially of saying you put a camera down the throat and you look at the lymph nodes that are adjacent to the mass and you biopsy those lymph nodes because the cancer generally does move to those lymph nodes and you can get a sample that way. That's one way. The second way is through interventional radiology, which is essentially doing a CT guided core biopsy where you look at the scan and based on where the mass is, you stick a needle in that area and you take it out. You sample it with a biopsy. The third way, which I'm passionate about, is what's called a liquid biopsy, which is crazy, sounds like science fiction, where you can take 10 cc's of blood on a patient and, believe it or not, be able to understand again the genomic underpinnings by just looking at the blood. So it's a pretty remarkable, this third way where you can do in many patients. You still need the biopsy either by bronchoscopy, EBUS, or a CT guided biopsy, but this is an additive, a test that's very simple to do, and we can really understand what's going on more confidently when we do that, both the tissue and the liquid.
Yeah, so I want to talk about this a little bit. So a tissue, tissue biopsies, I believe, are still sort of the gold standard. And these liquid biopsies, I agree, it does sort of feel like science fiction. But just for the audience, can you explain a little bit about why gold standard might still be tissue, and why just because maybe you don't see something in the blood doesn't necessarily mean it's not there?
This whole idea of liquid biopsies, if we step back, is that cancer does shed DNA into the bloodstream. And essentially, we now have the technology to pick up that cancer DNA in the blood and do the same sort of next generation sequencing that we're done on the tissue. What we know is essentially that not every patient with lung cancer is going to shed DNA into the bloodstream. And in fact, probably only 60 to 70% of patients with lung cancer are going to shed DNA. So when you do the blood test, if you find something, great. But there's probably going to be about 20 to 30% of the time that a patient does have lung cancer, but we're just not picking anything up. And in that case, we still need to default to the tissue biopsy. So don't be fooled if your blood test is negative. You could still have a gene that's in the tissue. And I think that's really, really important to understand that liquid doesn't solve all the problems. Again, if you have a blood test that's positive, I tell patients we don't even need to wait for the tissue. But if your blood test is negative, I tell patients don't give up here. We still may have an alteration or a gene of interest in the tissue that we can still make a treatment decision on.
Yeah, and this is something, again, kind of pointing back to what we were talking about a little bit earlier, that makes it challenging even for these some community docs to really understand and manage this. Like, is it tissue? Is it liquid? So just to sort of
Right.
recap for the folks that are watching, if something is found in the blood, we know it's there. It's not found in the blood, it does not mean it's not there. And that's why we're waiting for tissue. Can you talk a little bit about what the turnaround time is typically for tissue versus blood, in particular around this comprehensive or next generation sequencing?
The turnaround time for liquid is really nice. It's usually around 5 to 7 business days. So this makes it really unique. We do the blood test on Monday, and then by the following Monday, we have the results, and then we can make decisions on that result if it's positive. Unfortunately, the turnaround time for tissue is a little bit longer. It's usually 2 to 3 weeks. So it's sometimes hard to really wait that 3 weeks or 4 weeks when you're trying to get a decision in place, but blood solves a lot of that in a lot of ways if it's positive. If it's positive, blood really helps. This is why we do both. And there is a difference in turnaround time. There's no doubt about it. So that's really, again, imperative that we are doing both.
So that kind of jumps us right in. Well, one small comment. At Johns Hopkins, you're doing both, right? I don't want everybody to
Yeah.
expect that that's what
Yeah.
happens everywhere, because it isn't. But it's definitely worth the conversation with your healthcare provider wherever you're being seen. Should a biopsy need to be done, cancer confirmed, and then biomarker testing? Let's talk a little bit about the approved targeted therapies. What is a targeted therapy and how they match up with any mutations that might.
Yeah. I could go on for the remainder of this program talking about targeted therapies. It's really fascinating. We started in 2000 and maybe 9, 10, and 11 with just two targets. And that was EGFR and ALK. Again, these are relevant genes that we were able to identify and unfortunately develop these nice personalized therapy drugs, in these two cases, pills or oral therapies that blew chemotherapy out of the water. Like when you compared these drugs to traditional chemotherapy, I mean, there was just no comparison whatsoever. And this started to whet the appetite for us. And we started to say, well, wait a second, this is unheard of. And then the story, again, that was chapter one, maybe chapter two. And now we're starting to write a novel on this, and a very long novel. The longer the novel is, the better. There are now 8 more genes that we can identify and treat based on that genetic makeup. I mean, never in my wildest dreams when I started would I thought that this would be the case. So, I'm happy to list those genes. I had to think if I can get all 10 in my head. But just based on the gene makeup, again, you've got 10 drugs that you can give based on that. And this is the importance and the underscoring this criticalness of identifying these genes.
Yeah, I agree. I want to jump into the who, right? Lung cancer relatively falls into two sort of large buckets of non-small cell lung cancer and small cell lung cancer. Who should be receiving this testing?
There's no controversy here. Every patient with an adenocarcinoma, non-small cell lung cancer, should have genetic testing. Hard stop. Should have next generation sequencing. For patients that even early stage lung cancer or late stage. Patients with squamous cells, a little different, maybe a little controversy here. Most squamous cells we still do genetic testing on because we have been able to understand that there may be genomic mutations that we can wed to targeted therapies. It's not as frequent. I would say that every squamous cell should be considered for genetic testing. For patients with never smoking squamous cell, absolutely. For patients with remote squamous cell, absolutely. And then you have to realize that every biopsy we do, we cannot rule out sometimes that there may not be an adenocarcinoma component because sometimes these lung cancers could be both. They could be adeno and squamous. So unless you know for sure that this is a purely squamous lung cancer, there should probably be molecular testing done.
I think that's important to note for sure. You mentioned early stage, and I just want to touch on this a little bit because this is fairly sort of new to the game. This biomarker testing in the earlier stage patients. Can you talk about why that's important and why that is happening now?
Once again, quickly moving field. And if we had this conversation 5 or 10 years ago, we wouldn't be talking about this. But all these great drugs that we apply to advanced stage disease, stage 4 disease, that work so well, we've been able to now transition those drugs to earlier stage disease. And we just found out yesterday that these drugs that we've now moved to early stage disease provides a survival advantage. And so this is the first study, EGFR directed therapy called osimertinib, that in a study called the ADAURA study has shown now survival for patients who have completely resected lung cancer. We knew some early signals that were there, but we found out yesterday that this now leads to overall survival. And so this is the way we're moving. We're taking all these drugs that are targeted therapies that we talked about before and saying, hey, these drugs work really well for patients with advanced stage disease. Let's move them into early stage disease and see how they perform. And we're learning that we're curing patients with them now. So this is really, and this is the way drug development goes, and we're really excited.
I think what a lot of people might not know is that even for some folks, when lung cancer is found early and you do qualify for surgery, that a too large a number of patients will recur or the cancer will come back. So these
Yeah,
drugs are incredibly important. Either they're looking at them correct, well, they're before surgery and or after surgery. So again,
right.
having these conversations with your physician, even if you're
Absolutely.
diagnosed at an early stage, I think are really important. So we talked about next generation sequencing. We talked about the 10 biomarkers that we know have FDA approved targeted therapies for them. What's going on in clinical trials and what might a next generation, sequencing report show that could potentially make a clinical trial the best option for a patient?
Yeah, I tell patients either virtually or on platforms like this or in my office, clinical trial is not a bad word. I think 15 years ago it may have been a bad word because we just didn't have the drugs. But wow, there are some really great clinical trials out there now. Every drug that's coming out looks promising. And we've just begun to scratch the surface on these 10 biomarkers, right? This is a novel. We're writing a really nice book here about each gene that's a chapter and the targeted therapies that, go after these genes. And again, we've been doing this for 15 years. Imagine what the next 5 to 10 years is going to look like when we find these other genes that we develop drugs for. And that's why it's so important to do this next generation sequencing because we need to learn more. But this helps with drug development. We're looking at another gene called NRG fusions, which are rare but not approved yet. Just learning about them over the past year or so, but now new drugs for that. We're going to get to 15, 20 biomarkers, I think, in the next 5 to 10 years that are going to have an FDA approved therapy. We're just scratching the surface. Not only that, but the question is should we be using not only these pills for each gene, but should we be combining something else with these pills to give synergy and better outcomes? And so there's so much going on. I highly encourage patients to talk with their doctors about clinical trials. I have patients who seemed like they were at the end of their rope 3 years ago, and we were able to identify additional genes and coming to my office and saying remember 3 years ago and how well they're doing on these clinical trials. I mean, when I started 15 years ago in the field, like, I really was hesitant about the studies. They just they were chemotherapy studies. They were really just not looking at the right strategy, and we've come a long way. We really have. And I'm obviously I do clinical trials for a living, so of course I'm biased and say, "Hey, these are great," but you just got to trust me. These, we're really doing some fascinating science.
Yeah, I don't disagree. I think clinical trials need to continue to be sort of demystified, because I think they do have a stigma sort of associated with them. And I tell folks all the time in places like this, the living room or on the phone or in other areas of work, that it's not your grandfather or your great grandfather's clinical trial, because people are still concerned that they're going to be getting a placebo or a sugar pill. And quite
Right,
often, more often than not, and sort of the norm is you're either getting standard of care treatment, or the trial drug. But to your point, quite often these trial drugs are looking at targeting and taking sort of a personalized approach to the care.
right.
So I can't shout from the rooftops enough how important clinical trials are, and I can't thank people enough who participate in them, because, well, I think they don't get thanked enough for their participation, but these people are what are driving these
Totally,
drugs, these approvals, right? And without them, we wouldn't be where we
totally.
are today. You brought up immunotherapy, and I think I do want to touch on this just really quickly, because you're correct. This sort of direct to consumer marketing is leading all folks who are diagnosed to be thinking, I should be on an immunotherapy. How do we know whether or not somebody should potentially be on an immunotherapy versus a targeted
Well, I think for the most part, maybe the exception of two targets, KRAS
therapy?
G12C and BRAF V600E. I don't want to complicate that, but two of the
Mhm.
targets there may be a role for immunotherapy. But the other eight really, there really is no role right now. And this is why it's so important to get these results. We not only know that immunotherapy doesn't work for many of these targets, it can cause harm. And that's a problem. So we may be doing a disservice. Not only these drugs, they may not work. That's okay. Well, it's not, but if you're additionally causing true harm to the patient, then that's the censure here. And this goes back, underscores the importance of genetic testing for patients, of genomic interrogation. Because if you don't know the target, you can't give the targeted therapy. And if you don't know the target, you may give immunotherapy. And so I always tell community physicians, I tell medical students and residents and fellows who come to my clinic who are so eager to use immunotherapy. My phrase is pump the brakes on IO. IO is an abbreviation for immunotherapy. Just pump the brakes. Let's figure out what's going on in the tumor so we can make an educated decision on how to treat the patient. Let's not do a disservice to the patient. Let's get them on the right therapy based on the DNA makeup. And let's not just jump to conclusions because immunotherapy is all over the place. Don't get me wrong. Immunotherapy has a place, and an important place, in many settings, and is pushing the envelope as well. But it's specifically for those patients with targets, it's usually not. And I think this is what's dichotomized the field in lung cancer. You have those patients who do well with targeted therapy, and you have those patients who do well with immunotherapy. actually just dichotomize the research too. As you know, Michelle, I'm more of a targeted therapy guy. I do mostly targeted therapy trials, and some other people in my group do immunotherapy trials. And the
Yeah.
reason that this is dichotomized is because the patient population is different, and the biology is different, and the clinical trial design is different. So think about that as two separate fields, very little overlap.
Yeah, you had mentioned earlier when we were talking about the who should get the targeted therapy. We talked about the non-small cell adeno and squamous, and that we aren't quite there yet for small cell, but immunotherapy does play a role for small cell patients. Yes.
Yeah. Yeah. I mean, we have now two really good trials showing that addition of immunotherapy to chemotherapy backbone in small cell does not only improve outcomes, but it does push the tail of the curve. And this is just a way of saying there are people that are potentially cured with that, even with advanced disease. And so we are again, like targeted therapies, we're just scratching the surface on how to use immunotherapy, how to push the envelope, how to use them not only as single agents but in combination with other therapies. It's pretty remarkable what's happening here.
It really is. It's not that cancer is exciting, but to your again earlier point about where we were 10 or 15 years ago to where we are now, I mean, we have come leaps and bounds. I remember when I was early in this lung cancer space, and I'd go and I'd, to some of the conferences and sit in some of the sessions, and back then it was chemo versus chemo, right? And we were talking about, success rates or extension of life in a couple of months is what we were getting
Right.
out of it, and we're really talking about years for a lot of
Right.
people in this targeted therapy place. And to your point, years of a great quality of life.
I say that all the time. If we're extending life and it comes at the cost of quality of life, we're not moving the field forward. And that's what we were doing before. We were extending life by adding X drug to chemotherapy and maybe getting 2 or 4 months out of it. But that 2 or 4 months wasn't quality for patients.
Yeah,
And the feel, I
yeah,
mean, it's so exciting now. It's fascinating. It's
yeah.
fascinating. It's
It,
incredible.
it really, really is. Okay, so I'm going to close out, but I'm going to ask you out of this conversation today, what do you most hope that people take home with them or take back to their healthcare providers?
Yeah, I would say be an advocate for yourself, which, hopefully your physician is doing the right thing. And I see in the community that they are. But number one, be an advocate for yourself. Number two, partner with advocacy. You've got great organizations like GoTo. They're there for you. They're a phone call away or an email away to say, "Hey, let me get you through this." You got, the Bonnie Adair GoTo. It's you guys are great. So that's number two. And number three, I would just say make sure that you go to a place that has a village, not just one person, And just because I'm in an academic world doesn't mean, and yes, I'm flooded with wonderful resources for lung cancer, but make sure that there's a village that's helping. And then finally, and we said this before, clinical trials are not a bad word. There's just incredible science. And I'm not, if you were to talk, I'm a straight shooter. If you were to talk to me 10 years and we would have had this conversation, I'd be like, yeah, lung cancer's okay. You know, it's fine. It's good. It's not great. And it really has. I mean, lung cancer is the poster child for precision medicine. And all the other solid tumors get upset with me when I say that, but it's true. We are blowing out breast cancer. No offense to breast cancer, colon cancer, no offense to them. We are leading the way. There are other solid tumor malignancies that are just taking our lead. So, those are the things that I would say.
Yeah, I couldn't agree with you more. And I tell folks the same thing, that lung cancer really has sort of paved the path in this era of precision medicine, and rightfully so, and good for us, because for decades and decades we were falling way behind the curve. And
Yeah.
so that there is reason for hope now for anyone who might be diagnosed. And I also, and there really is no, this is not a biased statement. I mean, I also am a big advocate for advocacy groups. I mean, we are here for the patient
Yeah.
on so many levels. Obviously, my role is overseeing all the support and the services and the education that we provide. But when you talked about clinical trials, clinicaltrials.gov is almost an impossible
So
um,
hard.
thing to manage, right? But we do at GoTo have a personalized navigation service. So if you're out there and you are interested in exploring clinical trials or clinical trials that might be right for you, we do have personalized sort of concierge service to help kind of walk you through to find trials that you may qualify for that you can then go back and talk to your healthcare providers about. And the multidisciplinary team, when you said it does take a village, and I know quite often I hear, well, I really like my doctor, and I this is none of this is about whether or not you really like your doctor. It's about ensuring that you're advocating for yourself and getting the best care for your cancer. I want to say a huge, huge thank you to Medscape for giving us this opportunity to bring this patient conversation to the table today. Obviously, to Dr. Levy, thank you so much again. This is not your first rodeo with the living room, and we hope to see you live sometime in the new year.
Always a pleasure. Love doing it.
Sometime this
Anytime.
year. Yeah. Thank you, thank you, thank you. All of you watching live, those of you who will come back and watch this post live, Penn Media on the back end, Michelle Zay, who's also on the back end, the entire GoTo team. And of course, thank you so much to our supporters, Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Janssen Oncology, Merck, Mirati Therapeutics, Novartis, Regeneron, Sanofi, and Takeda. It's a very long list of people who also believe in what we're doing and ensuring that we are able to bring this content to you. So thank you all very much, and we'll see you next time.
So I'll be brave if you're brave. I'll be brave, but only if you're